All of you had a very interactive and useful, practical session, I would say, the previous session. This session also, you're going to be having on pain management. Some of the queries which you had, like what happens if this is not possible? What are the other alternatives? So from that point of view, we are going to be continuing on pain management itself today too. And for that, we have Dr. Sunil Kumar, who will be taking us through this session for today. And I hand over it to you, Dr. Sunil, to take over and take us through today.
Thank you. And good afternoon, everybody. Am I audible?
Yes.
Yes, sir.
Yes, we can hear you.
So in the previous class, we discussed about step 3 opioids, but we discussed only about morphine and fentanyl. So today we are going to discuss about methadone. So methadone, it is actually a new analgesic in India and is available for the last 5 years only. But methadone was available in India even before that, but not as an analgesic, but as an oral substitution therapy for those who has addiction or psychological dependence or opioid use disorder with other opioid medications. So with this introduction, today's we would be discussing about the pharmacological properties of methadone, and some of you might have heard about the problems or issues with the methadone, and so we would like to clarify that. Then if we start a patient on methadone, how we need to monitor the patient so that we can use the methadone safely. And you might be seeing many patients in your practice with pain, but all those patients would not be suitable to start methadone. So how can we identify the patients who will be benefited with methadone? And most importantly, how do you convert an opioid to methadone? Because there would be many conversions available if you look at the literature. So how can we do that? So these are the topics which I am planning to cover. And this, I would request all of you to be very active, interactive. So we would start with a patient history. So we have a 30-year-old woman who has diagnosed with Ewing sarcoma in 2016. And she was okay till till 2 years, but then she started to have pain on her back and legs. And the oncologist asked her to do an MRI, and that came out to be disease progression. And you can see there is extension to vertebral body as well as compression of L5 and S1 nerve root. And pleural metastasis was also there. So the disease is progressing. It is an advanced Ewing sarcoma. So this is the pain pattern she is describing. You can see the pain is on the right leg and on the back also. Even though this is marked as patchy, I believe these are the main areas where she feels more pain. So her description about the pain is that it starts at the back, low back, and then it radiates to the right leg. Um, it is like a burning pain and burning and shooting pain. And she gets some relief on lying down, but increases on any moments. So she was staying in the first floor of a building, and she was literally restricted to the bed in a particular room. She was unable to move because any movement will cause severe pain. So this is the pain score at the at rest. Okay. So um, so how are you going to treat this patient? Any of you can unmute and tell me. First of all, tell me what type of pain is this mostly?
The neuropathic pain.
Yeah,
Neuropathic pain.
yeah. Probably the low back pain might be nociceptive and neuropathic, but the one which on leg is predominantly neuropathic pain. So, how are you going to treat this pain?
This patient having spinal cord compression. So first mother step is to decompress the spinal cord by giving this radiotherapy to this patient. Then will be treated the pain with the morphine or other opioids.
Okay. Anyway, the oncologist deferred radiotherapy. So, what are the other options? Morphine and
We can use the methadone for this patient. It's a strong opioids.
okay. So, what is the indication to use methadone here?
If this patient is on morphine for a long time and he developed tolerance to this morphine, then we can start methadone for this patient.
Radiation. I can see there are some comments on radiation. Anybody else? Any other opinion? Okay. So this patient was under treatment from an anesthesiologist who was also doing palliative care. So actually, the oncologist told they are not planning any radiation, probably because that is not effective. And the anesthesiologist started her on morphine with the 10 milligram 4-hourly antithesis dose, and then amitriptyline was titrated up to 75 milligram. Pregabalin was up to 150 milligram BD, and dexamethasone also. But there is no pain relief. So what are you going to do now? Anesthesiologist in the groups.
So chronic cancer pain is mainly checkup just methadone.
Sorry, I couldn't understand.
So routine opiates is a fail in management of cancer pain. So another choice for the methadone.
Okay. Anybody else?
We can give an interventional pain management for this patient.
Yeah. So what would you do?
We can give a static block to this patient with long-acting local anesthetic agents.
So lumbosacral sympathectomy.
Lumbosacral?
Sympathectomy.
Okay. Okay. You mean chemical lumbar sympathectomy?
Yes, sir.
Okay. So anyway, this patient or the treating physician was an anesthesiologist, and he opted for epidural analgesia. So he put epidural with ropicaine and morphine. Initially, this patient had some relief with epidural analgesia, but even that little bit of pain relief was important for this patient. So this anesthesiologist, he changed the position of the epidural catheter, um, and he maintained the epidural catheter for 1 month, 2 months by reinserting at other sites. But uh, as the time went on, the pain relief also came down, and that was also not helping him her. So um, he thought of taking out the epidural, and he started her on oral morphine again. So she was put on 20 milligram of oral morphine with SOS dose. And then they removed the catheter. Then subsequently they increased the dose of morphine and titrated up to 40 milligram of morphine for hourly. Amitriptyline was also reintroduced. Pregabalin again reintroduced. But there is no satisfactory pain relief. Instead, she has delirium and myoclonus. So what are the options now? Okay, so anybody has any brighter ideas?
Any nerve involvement, cutting of the nerve root of
You mean right?
Cutting nerve root.
Yeah, that is rhizotomy, isn't it?
Okay, sir.
But those are procedures which was done previously, but it is found that even rhizotomy may not be helpful after some time. And for this patient with an advanced disease, I don't know how many neurosurgeons would do dorsal rhizotomy. Okay, so this is the time when this patient approached us. Okay. So, um, so actually, that was the time when methadone was available, and we had a few classes on methadone. So we thought this patient would be a good patient to start on methadone. Okay, so when we looked at the literature, how to start methadone, and there are many methods, and you can see 3-day switch method, rapid conversion stop and go method, ad libitum stop and go method, German model, outpatient titration. So we were confused how to go about, but we also understood that the people whom we taught, they use 3-day switch and they recommend 3-day switch. So before you convert morphine to methadone, you should know the potency, isn't it? What is the potency of tramadol compared to morphine? Anybody? Potency of tramadol? What is the potency of fentanyl? Okay. So the potency of tramadol is, yeah, Dr. Bhargav Dev says it is 1/10. Yeah, tramadol is 1/10 as potent as morphine. That means 100 milligram of tramadol is equal to 10 milligram of morphine. And fentanyl is 100 times more potent than morphine. So, but the ratio is constant, whatever be the dose of morphine in case of tramadol and fentanyl. But you look here, in case of methadone, you can see, depending on the dose of morphine, the potency of methadone varies. But so for this patient, we decided to convert her to methadone. So how do you calculate? So she was taking morphine 6 times, and that is 40 milligram 4 hourly. That means 240 milligram. So the equivalent would be, if you want to convert this dose of morphine, that is the morphine between 100 to 299, the potency is 8:1. So 240 divided by 8, 30 milligram. And when you convert an opioid to another opioid, even though you got a calculated dose, you would not give that much opioid, because there is something called as incomplete cross tolerance. The opioids, even though they are mu agonist, they act differently on the mu receptors. Their potency and their combining capacity, all are different. So usually it is a dictum to reduce 30% of the total dose. So even though we got 30 milligram, we have to reduce 30% from this 30 milligram. So 30% of 30 milligram is 9 milligram. So the total dose of methadone required would be 21 milligram. Okay. So this is the time where we were afraid, because we have had about methadone, and we got some classes, and we understood that methadone is not an easy drug to handle. So we thought of even though we thought of 3 days switch. So how a 3 days switch look like? So you got total 21 milligram of methadone. So this is how you would give or you would institute the methadone if you follow 3 days switch. So on the day first, you have to add 1/3 of the methadone of the total calculated dose. So you calculated, you got a total dose of 21 milligram. So 1/3 of that would be 7 milligram. And you have to reduce morphine by 1/3. So you added 1/3 of methadone, you reduce morphine by 1/3. And on the second day, you add another 1/3 of methadone and reduce morphine by another 1/3.
Excuse me, someone, Dr. Sunil, someone has message in the chat to re-explain that dose conversion of methadone, please.
Okay.
It's Dr. Premnath has asked, can you explain calculation of methadone again?
So this is an old calculation which we are not following now. But anyway, so this patient was taking 40 milligram 4 hourly. So the total dose of morphine would be 40 into 6, 240 milligram. So there is an EQ analgesic conversion table. And from this, you can see that this patient is taking morphine between 100 to 299. So the conversion ratio or the potency is 8:1. So you have to divide 240 divided by 8. That will give you 30 milligram of methadone. But you will not convert this 30 milligram to methadone, because there is something called as incomplete cross tolerance. That means if both methadone, morphine, fentanyl, all are mu agonist, but their binding capacity and their adherence to the receptors, these all are different. So you will not give full dose of methadone that you have calculated. You will reduce it by 30%. That is incomplete cross tolerance. So you reduce 30% of 30 milligram, which is 9 milligram. So you have to reduce 9 milligram from the total dose. That would be coming to 21 milligram. So this is the total dose of methadone that you need to give to the patient. Now, if you give 3-day switch, that means by taking 3 days, you convert all of the methadone and stop morphine. That is what 3-day switch means. So on the first day, you will give only 1/3 of the methadone. So total dose was 21 milligram. So 1/3 would be 7 milligram. And total dose of morphine was 240 milligram. You have to reduce the morphine by 1/3. So you have to reduce 240 minus 80. That is 160 milligram. And on the day second, you will add another 1/3 of methadone. That is 7 plus 7, 14 milligram. And reduce morphine by another 1/3. That is 160 minus 80, 80 milligram. On day third, you will add another 1/3 of methadone. So that is whole calculated dose of methadone. That is 21 milligram. And you have to stop morphine. So this is how 3-day switch happens. But as I told you previously, we were afraid to do this. And we did another thing. What we did on first day, we gave 2.5 milligram TID, that is 7.5 milligram of methadone, and we reduced the dose of morphine by 1/3 from 40 to 25. And within 3 to 4 days, patient was telling that she is able to sleep now better. And we didn't convert methadone on the second day, or we did not add methadone, another 1/3. Rather than we waited till day 7, and we added another 1/3 of methadone. That then it went up to 5 milligram TID. We reduced the dose of morphine by another 1/3. So she had better pain relief. And on day 14, that is on day 14, we increased the dose to 7.5 milligram TID. Actually, by day 14, this patient came to our OPD by walking. So this patient was, I told you, she was completely confined to a bed without, she was unable to move. But by day 14, she could walk to our OPD. So that was the type of pain relief she achieved. And so so on day 14, we converted whole of the methadone, or we give full dose of methadone, that is 7.5 milligram TID, and stopped morphine. Okay, so this patient had excellent pain relief until she died. So what was the reason for this pain relief? Or it is important for us to understand the pharmacology of methadone. Why this patient got good pain relief? So methadone is an isomer of S-methadone and R-methadone. All the preparations are available as an isomer of R-methadone and S-methadone. And methadone act on all the opioid receptors as agonist. That is on mu, kappa, and delta, it acts as an agonist. Whereas morphine, fentanyl, they all are mu agonist only. Okay. And methadone is an NMDA antagonist. That is N-methyl D-aspartate antagonist. So which is the other NMDA antagonist, you know?
Ketamine.
Ketamine.
Yeah, ketamine. And methadone can also, it will also inhibit the reuptake of noradrenaline and serotonin. Which group of medications has this action? Inhibition of reuptake of noradrenaline and serotonin.
Tricyclic antidepressant.
Yeah, thank you. Tricyclic antidepressants. So it acts like tricyclic antidepressant also. Okay. But in addition, it also act on human either agogo related gene channels, and it can cause tau points, which can lead to a ventricular fibrillation and death of the patient. So the first three are beneficial effects of methadone, but the last one is one of the serious side effect of methadone. Okay, now we will look a detail into the actions of methadone. So it acts on opioid receptors, mu, kappa and delta as an agonist. So you know that if it acts as an agonist, it will produce the physiological action. So it will produce analgesic effect. It can produce constipation, nausea, vomiting, pruritus, and if it is in the toxic dose, can lead to respiratory depression. Now, what is the action due to NMDA antagonism? So here you can see 4 patients, patient A, B, C, and D. All these patients are on unusually high doses of morphine. You can see one patient is taking more than 10,000, another patient is taking 7,000 milligram per day. So why these patients are on this much high doses of morphine? What would be the reason?
They have developed tolerance.
Sorry, can you speak a little more loud?
They have developed tolerance. These patients have developed tolerance to morphine.
I couldn't hear you properly.
If they have developed tolerance to morphine, is that what is? That's what she's telling.
Explain what is meant by tolerance. What is tolerance?
The same drug dose will give a lesser effect.
Yeah. So in other words, you can say that to get the same effect, you have to increase the dose of the medication. So suppose a patient had pain and you started him on 5 milligram of morphine, but after some time, this patient might require 10 milligram, and it went on and finally they reached on very high doses of morphine. So this is known as tolerance. Okay, so tolerance can develop to opioids, but not very common, but it can. So probably these patients develop tolerance, and that's why they are on such high doses of morphine equivalents. Okay, and all these patients were started on 30 milligram of methadone per day, regardless of the dose of morphine they are taking. So all the 4 patients was given 30 milligram of methadone, and all these patients got very good pain relief. So what do you understand from this? So morphine was stopped, and all of them was started on 30 milligram of methadone per day, and they got good pain. So what did you understand from this? Or what's your inference? Okay, so NMDA receptors are involved in the occurrence of tolerance. So when the methadone was given, that was reversed. And that's the reason this patient got good pain relief. So if methadone can actually prevent and reverse tolerance to opioids. Sorry, 1 minute. So that's the importance of NMDA antagonism by methadone. Okay, so in addition to that, you also know that NMDA receptors, as methadone is an NMDA receptor antagonist, it can have beneficial effect on neuropathic pain as well. Okay, so now this is the history of a 50-year-old woman. She is diagnosed with carcinoma of the breast and underwent modified radical mastectomy, radiation, and chemotherapy. Now she has local recurrence and has severe pain on the chest, and which is radiating to left arm. Now she is on tramadol 100 milligram every 6 hourly and amitriptyline 100 milligram HS. She is also receiving fluoxetine 20 milligram BD. Okay. And this patient, after some time, after 2 weeks, presents to you with agitation, anxiety, restlessness, disorientation, sweating, hypothermia, tachycardia, nausea, vomiting, and tremor. On examination, there is muscle rigidity, hyperreflexia, myoclonus, dilated pupils, and ocular clonus. So what is the diagnosis?
So opioid withdrawal.
Opioid withdrawal. Okay, but yeah, some of the things looks like opioid withdrawal, but this is not exactly opioid withdrawal.
Serotonin syndrome.
Yeah, this is something called as serotonin syndrome. Okay, so any medications which causes serotonin or inhibition of reuptake, thereby increased serotonin levels, can cause something called as serotonin syndrome. So methadone is, as I told you, it acts like tricyclic antidepressant. And tramadol is another medication which also has this tricyclic-like action. So when you give tramadol or methadone along with these medications, like SSRIs or MAVO inhibitors, this can produce serotonin syndrome. And the chance of producing serotonin syndrome is vary with the medication. And there is low chance of producing serotonin with the nortriptyl, but whereas it is high with fluoxetine, sertraline, paroxetine. So what are the, how do you detect it is serotonin syndrome? So there would be cognitive changes, autonomic instability, and neuromuscular changes. So you can see all those symptoms which we have seen in that patient are here. Agitation, restlessness, confusion, nausea, vomiting, tachycardia, hyperthermia, tremor, hyperreflexia, clonus. So all these are, if there are various DDs, differential diagnosis, but if a patient is on methadone and concurrently with tricyclic antidepressants or any other medications like SSRIs, and if they present with any of this, please think whether it is due to serotonin syndrome. This is a rare condition, but it can occur. And you also know that because of the tricyclic antidepressant-like action, it has an advantage in treating neuropathic pain. Okay. So we have another patient, a 70-year-old man, who is taking methadone 50 milligram 12 hourly for last 2 months and is diagnosed with carcinoma of the buccal mucosa and is currently undergoing treatment. He is admitted with fever and restlessness, and on investigation, you found out that he has urinary tract infection. So you started him on injection ciprofloxacin 200 milligram IVPD, and also restlessness was treated with the haloperidol. Later, this patient was complaining of palpitation and syncope. Any idea why this patient has palpitation and syncope? Anybody? Anaphylaxis, side effect of haloperidol. Then Dr. Kavita says check ECG. Okay. So as you told, an ECG was taken. So this is the ECG looks like. So what's your diagnosis?
Ventricular tachycardia.
Yeah, this is Taussight's deep points. Okay. So Taussight's deep points, which we have described earlier, which why methadone or how methadone produces Taussight's deep points. So methadone acts on human either agogo related gene channel. Okay, and it can actually increase the QT interval, which can lead on to Tausside points, to ventricular fibrillation, and to sudden death. Most of the time, Tausside points may not cause ventricular fibrillation, but sometimes it can cause ventricular fibrillation and end in death of the patient. But this is especially true when you add medications which have the ability to increase the QT interval and themselves also can produce Tausside points. So injection ciprofloxacin and haloperidol, those are two medications which can increase the QT interval as well as can produce Tausside points. Okay. So, as many of you might have heard about this earlier also, but I think we need not worry about this. Here, there is a study by MD Anderson Cancer Center, and they recruited 100 patients for starting on methadone, and they did serial ECGs, regular ECGs. And what they found out was analyzing ECG, they couldn't find out any patient developing Tausside points or ventricular fibrillation. And even though some patients had some increased QT interval, but none of them developed Tausside points or ventricular fibrillation. And you can see the median methadone dose was 23 milligram. The range is from 3 to 90 milligram. So this is one study which says that when we start patient on a low dose methadone, usually you need not go beyond 50 milligram per day. And in my experience, I have not gone above 50 milligrams per day for any patients. So if you start patient on low dose of methadone, it will not cause Tausside points or ventricular fibrillation. But you have to be very careful. What are the other medication these patients are getting? Because that is also going to interact with methadone. So here is a list of medication which can actually increase the QT interval and Tausside points. So you can see these are common medications which we use in palliative care. Fluoroquinolone, ciprofloxacin, levofloxacin, then macrolide antibiotics, azithromycin, erythromycin, clarithromycin, then SSRIs, citalopram, fluoxetine, citalopram, sertraline, then ondansetron. So these all are medication, haloperidol. These all medications are used very commonly in palliative care. So when you prescribe methadone, be careful about these medications. And it may not be possible for you to remember all these medications. So better you should take a printout and put it in your doctor's room or somewhere else so that we can refer easily. So you can see there are even pantoprazole that can produce, there is a risk. And so as we told earlier, methadone has two uses. One is as an analgesic and the other is to as a substitute for opioid use disorder, for treating opioid use disorder. And now we'll move on to the pharmacokinetics. So how methadone is absorbed? It is again absorbed from the upper small intestine, like morphine. The bioavailability of morphine is only about 20 to 30%. But in case of methadone, it is up to 80%. What is bioavailability?
Oral absorption.
Sorry. Bioavailability.
Oral absorption of the drugs.
Absorption, it is a little bit different. Absorption and bioavailability.
After the first pass,
Mm.
is it the availability of the drug in the system after the first pass metabolism, after the peroral administration or absorption?
Yeah. Good. So it is the percentage of the drug available in the systemic circulation after peroral administration. So morphine is 100% absorbed from the gastrointestinal tract, but morphine only 10 to 20% would bypass liver and will be available in the blood as morphine. So that's what bioavailability. So only 20 to 30%, or some people say it's only 20% of morphine is the bioavailability of morphine, but here it is more. And methadone can be administered sublingually also. But we told that morphine should not be absorbed sublingually because its absorption is very erratic. We cannot predict how long it will take and what would be the effect. If after sublingual administration of morphine, if somebody says, I have good pain relief, you have to understand that they have swallowed it, and that's why they have pain relief, good pain relief. But in case of methadone, it can be administered sublingually as well as parectally. Injections are available, but not in India. So we have only oral preparations. So after administration, it is distributed mainly in brain, GI tract, kidney, liver, muscles, and lung. So what happens after immediately after administration? It will be available in the blood for pain relief for some time, about for 2 to 4 hours. But then it disappears into the tissue binding sites. Okay, so you can see it goes into the tissue binding sites, and when these tissue binding sites get saturated, then only the methadone will be freely available in the bloodstream. So this is what happens. You can see these are the tissue binding sites which get saturated, and only then the methadone will be available for continuous action in the blood. So methadone will take, the half-life of methadone is about 22 hours. That means it will take methadone will take about 5 half-lives to have a sustained concentration in the blood. So 5 half-life means it is approximately 5 days. So, but it is seen that in people who are elderly or patients who has liver failure, this will even take up to 2 weeks to have sustained blood levels. So normally methadone will take about 5 to 7 days to have a sustained blood level, and thereby the pain relief, it will take about 5 to 7 days to get good pain relief. So this is one of the most important thing that you have to understand. In case of morphine, it will take only 1 day, but whereas in case of methadone, it will take up to 5 to 7 days before it gives good pain relief. So that's the time you have to wait. You should not increase the dose of methadone till 5 to 7 days in normal people, but in elderly and people with liver function, you may have to even wait for up to 2 weeks. Okay, now how methadone is metabolized? It is just like in liver, morphine, it also happens in liver, but it is not due to glucuronidation like morphine. Here, methadone is metabolized by cytochrome P enzymes. So you can see there are various cytochrome P enzymes involved in so various cytochrome enzymes are involved, and you know that there are many other medications which are metabolized by the same route, that is by various cytochrome P enzymes. So that will lead to drug interactions. So this is another issue with methadone. So what happens? There are some medications which can actually inhibit the cytochrome P enzymes, and some inducers also. So what happens if cytochrome P inhibitors are given to the patient? So cytochrome P inhibitors, strong cytochrome P inhibitors are grapefruit, protease inhibitors. What are protease inhibitors? Which group of medications comes in protease inhibitors?
Indian Army.
Sorry, I didn't.
Indian Army.
Oh, okay, yeah. So ART medications, antiretroviral therapy. Okay. Then azole antifungals like fluconazole, ketoconazole, cyclosporin, cimetidine, macrolide antibiotics, amiodarone, and non-DHP calcium channel blockers like diltiazem and verapamil. So all these are strong cytochrome P inhibitors. So they will inhibit the cytochrome P so that the methadone will bypass the liver, and there would be more concentration, which can lead to toxicity of methadone. So if you start any of this medication, it is recommended that you should reduce the dose of methadone by 25%. Okay, but if you look at the cytochrome P inducers, phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, carbamazepine, if you give these medication along with a methadone, then the dose of methadone available in the blood would be less. So you have to look for whether this patient is having any withdrawal symptoms, because the dose of methadone is reduced in blood. Patient can have more pain, sometimes even withdrawal. So be careful about this medication. These are not the only medications which are cytochrome P inducers or inhibitors. So there are a lot of medications. So again, as I told you earlier, you have to take a printout of this and paste it somewhere if you are practicing with methadone. Okay. So now how methadone is excreted from the body. It is the major route of excretion is through bowel. So it is supposed to be safe in renal failure. But morphine is excreted through kidney. So it will accumulate in case of renal failure. So methadone is a safe medication in patients who has renal failure. And duration of action of methadone is 8 to 12 hours. So you need to give only twice or thrice per day. But in case of morphine, it is 4 hours. Okay. So that is one advantage of methadone. So now we'll see who are the candidates or for which patients you can start methadone. So methadone can be started as an adjuvant. That means you can give methadone along with other opioids in small doses to potentiate the action of the other opioid. Suppose a patient is on 10 milligram of morphine every 4 hourly, but this patient is particularly complaining of pain only at night. So you may add 2.5 milligram of methadone at night so that they will get good pain relief. So that is then it is called as an adjunct. Then if you are practicing pain medicine or palliative care, you might have seen that some patients may not respond to opioids like morphine, fentanyl, or any other medication. So they are refractory, their pain is refractory to other opioids. So in such situation, methadone can be used. And as we told earlier, a patient in pain with significant renal impairment and methadone act for 8 to 12 hours. So if the patient has interrupted sleep at night, even though you give double dose of morphine at night, so this patient can be converted to methadone so that he will have more analgesia during day and night. So need for long-acting opioids. And we saw that patients who is on high dose of opioids due to tolerance can be benefited with methadone. And there is something called opioid-induced hyperalgesia. So in such patients also, methadone might be useful. Then poorly controlled opioid-induced adverse effects with other opioids. So a patient who is on morphine, maybe 10 milligram 4 hourly, and he is developing delirium, myoclonus, all those symptoms. And when you reduce the dose, the patient has severe pain. So in such patients, you might use. And true morphine allergy. Some patients might be allergic to some medication or even anaphylaxis can develop. But if the patient is anaphylactic to morphine, methadone can be used because methadone is from a different chemical group. And if the patient has complex neuropathic pain, so we saw the first patient who had Ewing sarcoma. She had compression of nerve roots and extension of tumor in the pelvis, which caused complex neuropathic pain. In such patients, methadone might be useful. So these are the indications to start a patient on methadone. And there are some inappropriate candidates to use methadone. If the patient gives a family history of sudden unexplained death, then it should not be used because torsade points run in families. And if you use methadone, that can add on to the problem. Then congenital QT syndrome. And what is the normal corrected QT interval? Normal corrected QT interval. Anybody? Okay, it is 450 milliseconds.
Distributed in the general population. Normal values for
sorry. And for 60 milliseconds in female. Okay, that's the normal corrected QT interval. And if the patient's corrected QT interval is more than 500 milliseconds, then methadone should not be started. If the patient has poor cognitive function, that means they are unable to express how much pain relief they have. You have a patient with advanced dementia who is unable to communicate. In such patients, you should not give. And there should be a reliable caregiver to administer methadone. Okay. And like fentanyl, here also methadone is not useful if the patient has acute severe pain or acute, because it is going to take long time, isn't it? 5 to 7 days at least to get good pain relief. So methadone should not be used in these situations. So how do you monitor if the patient is on methadone? So the monitoring should be aligned with goals of care. If we have a patient who has an very advanced malignancy or advanced lifelong disease, in such patients, the goal of care would be only comfort, isn't it? We are not going to treat him very aggressively, or they are not suitable for any interventions from any other specialties. And in such patients, the goal of care is comfort care. So in such patients, you need not worry about these investigations. But if the patient is undergoing any palliative or oncological interventions, then you should check baseline ECG and also electrolytes. Hypocalcemia, hypomagnesemia, and hypokalemia. All this can lead to increased QT interval, which can lead to torsade points, ventricular fibrillation, and death. That's the importance of checking calcium, potassium, and magnesium. Then after baseline ECG, you can do an ECG after 2 to 4 weeks. Then once the dose reaches to 30 to 40 milligram, again, you can do an ECG. And when dose reaches 100 milligram, you do another ECG. Okay, this is how you have to monitor the patient. So this is the methadone available in India. It is 5 milligram tablet, and the syrup 1 ml contains 5 milligram. So we do not have injections available. Okay, now we will move on to the methadone conversion. Even though we talked about a patient for whom we started methadone, that was the old conversion methods. We never use it now. So what is the present method of methadone conversion? So this is very simple, and this is from Journal of Pain and Symptom Management. This is a consensus white paper by hospice and palliative care physicians. And if the patient is taking less than 60 milligram of oral morphine per day, you can start that patient on 2 to 7.5 milligram of methadone. Okay. And if the patient is taking between 60 to 199 milligram of oral morphine, and if the patient is less than 65 years old, the conversion ratio is 10:1. So between 60 to 199 milligram of oral morphine and patient is less than 65 years, the ratio is 10:1. So 10 milligram of morphine would be equivalent to 1 milligram of methadone in these patients. But if the patient is taking more than 200 milligram of morphine, or if the patient is more than 65 years old, the ratio becomes 20:1. So 20 milligram of morphine would be equal to 1 milligram of methadone. So the dose of methadone varies depending on the dose of morphine. So the potency is not linear. in case of methadone. But for other opioids, the potency is linear. And another important thing is that whatever be the dose of morphine the patient is taking, never start the patient for the first time more than 40 milligram per day. So that's the maximum initial dose that we can start for a patient. 40 milligram, maximum 40 milligram per day. Okay, now we will move on to some conversions. How can we convert other opioids to methadone? So we have a 37-year-old man who is diagnosed to have carcinoma of the buccal mucosa and another second primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And after some time, he had a level 2 nodal recurrence, for which he again underwent surgery. So you can see this patient who is sitting in a chair with his head down. So he's describing his pain, which starts inside the left ear, going to the lateral side of forehead, and then to submental region, which is a pricking type of pain. It is always 10 by 10. So what type of pain he is experiencing?
Neuropathic pain.
Okay, why neuropathic pain?
So maybe because of lesion of brain is involved.
Yeah. What are the points to say this is neuropathic pain?
So neuropathic pain can be like a pricking, burning, or lancinating type of pains.
Yeah.
Then
What are the other
And the
indicators?
radiation,
To say-
radiating region, right, also indicates it could be neuropathic.
Anything else? And there are, I think there are 3-4 points by which you can say the patient has neuropathic pain. One is you should elicit a history which is suggestive of a lesion or disease affecting somatosensory nervous system. You should elicit a history which is, you should elicit a history of a lesion or disease affecting somatosensory nervous system. Here we have a patient who has carcinoma of the buccal mucosa and papillary carcinoma of the thyroid as well. So this malignancy might be infiltrating into the trigeminal nerve areas, and so that is the history suggestive of a lesion or disease affecting somatosensory nervous system. So that is the one point. Second point is neuropathic pain is always neurodermatomal in distribution. So if the disease or lesion affect a particular nerve, the pain would be from that the area supplied by that nerve. Here you can see that this patient is complaining of pain which starting inside left ear, going to the lateral side of forehead and also to submental region. So that means it is in the area of mandibular nerve distribution. So that is neurodermatomal in distribution. So that is the second point. Third point is the quality of pain. Quality of pain usually would be burning, pricking, electric shock like. So all those are characteristics of neuropathic pain. And the fourth point is the patient can have abnormal sensations. So abnormal sensation can be either decreased sensation or it can be increased sensation. So examples of increased sensations are allodynia and hyperalgesia. Whereas decreased sensation, the patient may complain of numbness. Okay, so here we can see that this patient has the first three things. History is suggestive, then neurodermatomal distribution, the quality of pain looks like neuropathic pain. So that's why it is neuropathic pain. So this patient underwent mandibular nerve block from outside 3 times without any pain relief. So this was the treatment the team have given they gave injection morphine after this mandibular nerve block, but it produced toxicities. So they stopped injection morphine and started him on morphine, like 10, 15, 10, 30. This is only 4 times, and you can see the dose is not standard. I think they might be titrating to reduce the toxicities with 10 milligram SOS. And even this was causing toxicities, and patient is in severe pain. And they also tried him on various adjuvants. And when this patient came to us, this was the prescription: morphine, pantoprazole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac patch, paracetamol. So, is this can we start, or is this a suitable patient to start on methadone? So, no, too many interactions. Yes, very good, Dr. Aditi. But don't look at medications now. Is there any indication to start methadone in this patient?
Patient on diclofenac
That is not.
renal toxicity.
Yeah, I can see Dr. Subi says morphine toxicity. Yes. So this is one indication, morphine toxicity. What are the other indications to start on methadone? There is no renal. The patient is not. We are talking about methadone. So what I am asking, what are the indications to start this patient on methadone?
Ciprofloxacin cause the QT and cause at this point.
That's not the indications. What are the indications? Yeah, neuropathic pain, complex neuropathic pain, because this patient was already received nerve growth and she was on various adjuvant.
Sorry to interrupt. I think Dr. Kasi Rajan, there is some disturbance. If you could stay on mute when you're not speaking, please, because there is one background. I think, am I only listening, or because there is one hindering background noise?
Sangeet, please note.
Yes, ma'am.
Dr. Kasi Rajan, whenever when he was speaking, it was there. So I'm not pointing out or telling anything like that. But if someone is not speaking, please stay on mute. When you're speaking, unmute. And there is some disturbance. That's why I'm mentioning, doctor. And Sangeet, have a look at it, because
Sure,
now
ma'am.
it's not there.
Now it's all muted, ma'am.
Okay.
Yes, and not that we are muting anyone, only because of the disturbance. Okay, thank you.
Yeah. So here the indications are: one is complex neuropathic pain, and as you told, morphine toxicity. And the other indication is it is not responding to other opioids. Patient have received tramadol and morphine. So refractory to other opioids is also an indication to start this patient on methadone. Okay. So these are the 3 indications. So before you start this patient on methadone, what all should you do?
Stop the other drugs which causes interaction, like ciprofloxacin, find an alternative adjuvants.
We will come to that. We will come to that. Even before that, you have just thinking of
Investigation.
starting whether this patient would be a suitable candidate. So you found out that, okay, there are some indication, but there are some other things which you need to ask the patient and caregiver to find out whether this is a suitable patient. What are those things?
Regarding whether they can come for follow-up, whether they have a caregiver to who's taking care
So
of them.
you should also ask about history of sudden unexplained death.
Family history.
And as you told, does this patient has a reliable caregiver and is he cognitively okay? All these things need to be looked into. And then what are the investigations you are going to do? Investigations? Yeah, you can
Baseline
see
investigations of ECG,
ECG.
potassium, magnesium, and calcium.
So, but I told you earlier that the investigation, it should be aligned with the goals of care. So, if this patient is not going to benefit with any of the oncological or palliative oncological interventions. So, this patient is a patient who would be fit for only comfort care. So, actually, no investigations are needed. But if you want to do investigations, then you might do ECG and calcium, potassium, and magnesium. So, okay. Okay. Do you have any concerns with any of the present medications when you start this patient or methadone? Can any of these medications interact with the methadone?
Enzyme cytochrome P enzyme inducer like the ciprofloxacin.
Yeah, ciprofloxacin, pantoprazole.
Yeah. So there are a few medications which can actually interact with. So escitalopram, ciprofloxacin, and even pantoprazole has some interaction with methadone. So either you have to switch it to some other medication or you have to stop this. So what would be the dose of methadone for this patient? Can you calculate the dose required for this patient? Dose of methadone. Take 1 minute. Please calculate. Anybody has the answer? What is the dose of methadone to be started for this patient?
So there are some answers in the chat box, 6.5 mg.
5 milligram. Yeah. Okay. Yeah, good. So let's see how to calculate the dose of methadone. So this patient, first of all, we have to calculate the total daily dose of morphine he is taking. So it is 10, 15, 10, 30. That means 30 plus 10, 40, 55 plus 10, 65. So total it is 65 milligram of morphine he is getting. So what would be the conversion ratio, or what is the potency of methadone at this dose of morphine? So it is between 60 to 199 milligram, and the patient is less than 65 years old. So the conversion ratio would be 10:1. Okay. So we have to divide 65 by 10. That is 6.5 milligram of methadone. So how do you give this 6.5 milligram of methadone to this patient? How do you start? I told you that methadone has a duration of action of 8 to 12 hours. Okay. So what dose would you start? It will depend on the type of formulation available to you. So if you have syrup, it is 1 ml in 5 milligram. You can dilute and make it 1 ml in 1 milligram. But if you have a tablet, it is 5 milligram, you can break it into 2, and maybe 2.5 milligram would be the minimum dose that you can administer. So this would affect your decision. Okay. So if it is tab methadone, you can give 2.5 milligram BD. We are starting only 5 milligram. But if you have syrup also, maybe 3 milligram BD or 2 milligram TID can be given. So what are you going to do for some relief for this patient? You have already started him on methadone, but we know that it will take about 5 to 7 days to get a good pain relief. So what would you do? You have to start the patient on morphine, on the previous dose of morphine. He was taking 65 milligram of morphine. That means it is approximately 10 milligram 4 hourly, isn't it? 10 milligram 4 hourly would be 60 milligram. So you have to give morphine also, but be careful. What I have written here is tab morphine 10 milligram Q4H SOS. Usually when we prescribe morphine for a patient, it would be 10 milligram Q4H and SOS. Here it is only 10 milligram Q4H SOS. What does this mean? Anybody?
Methadone will potentiate the action of morphine.
Okay. But what is the difference between the usually prescribed morphine and the morphine I have written here?
Oh.
Sir,
Since
with minimum of 4 hours interval.
minimum of
4 hours interval.
okay. Yeah. But this also means that you can give morphine on a 4-hourly SOS basis. Okay. That means you need not give morphine every 4-hourly. Only if needed, you can give morphine. But that in 4-hourly fashion if needed. So, for example, you can give, suppose you give methadone at 6 a.m. in the morning, 2.5 milligram. You will ask the patient, do you have pain? So if the patient has pain, you will give morphine 10 milligram. 10 o'clock again, you can go and ask, do you have pain? Patient says, no, I do not have pain. Don't give. Again, 2 p.m. you are asking. Patient says, no, I do not have pain. You are not giving. Then maybe after 6 o'clock, patient says, I have pain. Give morphine. So that's what Q4H SOS means. Okay. So the prescription would be like this. Tab methadone. If you have only tab, it is 2.5 milligram BD, or syrup methadone, 3 milligram BD or 2 milligram TID, along with the morphine, 10 milligram Q4H SOS. Paracetamol can be continued. And instead of ciprofloxacin, because that is going to increase the QT interval as well as can produce dose points. So you have to substitute with another antibiotic. So one safe antibiotic would be amoxicillin. And acetylopram. This patient was receiving acetylopram, but the treating team added thinking that this patient has severe depression and that's why he has no pain relief. But actually, his problem was the severe physical pain. So we stopped the citalopram and this patient had very good pain relief till his death. Okay. So now I am moving on to another patient, a 39-year-old woman with CA pancreas who has stage 4 disease with liver, lung, and splenic metastasis. She underwent chemotherapy, but because of the progressive disease, the oncologist stopped it, and she was receiving palliative care from the oncologist. So her main problem was the severe pain, and you can see the pain pattern, which starts on the left lateral chest and going to the right lateral chest through the back. And this pain was there for the last 2 months, which she described it as a stabbing pain. And most of the time it is 10/10 and it reduces to 8/10 when the patient takes morphine, tramadol, and paracetamol. So this is the medication which she is getting: morphine, tramadol, paracetamol, gabapentin, amitriptyline, bisacodyl. And even with this, the patient had severe myoclonus. So is this a patient suitable to start on methadone? Or are there any indication to start on methadone? Any indication to start on methadone? Yeah, pain persists with opioids. That is refractory to other opioids. Yeah, that's a good one. Yeah, what are the other indications? Morphine toxicity, isn't it? Myoclonus. And one more. It is complex neuropathic pain, which is not relieved with amitriptyline and gabapentin. Okay, so those are the indication to start this patient on methadone. So before you start, you know that you have to ask about any unexplained death in the family, reliable caregiver, ECG, calcium, potassium, magnesium. That is not needed in this patient though. So what is the dose of methadone this patient requires? Please calculate what would be the dose of methadone required for this patient. Okay, I can see 8 milligram. Yeah, is there any cheap alternative to methadone? No, methadone is not costly. Methadone is as comparable to morphine. And if you give high dose of morphine, and in such situation, methadone would be a cheaper option. I see Dr. Shanmugapriya has a different answer. Dr. Kasirajan also has a different answer. It is 12 milligram and all the others has got it 8 milligram. Okay, let's see how to calculate. So this patient is taking 20 milligram of morphine every 6 hourly. So the total dose of morphine she is taking is 80 milligram. But you have to also understand that all the opioids need to be converted into the equivalent doses of morphine. So this patient is not only taking morphine, but also tramadol. So you have to convert that tramadol to equivalent doses of morphine. So tramadol, she is taking 100 milligram TID. So total 300 milligram of tramadol, that would be equivalent to 30 milligram of morphine. So this is the total dose she is receiving is 80 plus 30, 110 milligram of morphine. So this patient is taking, age is only 39 and she is taking morphine between 60 to 199. That is 110 milligram. So the conversion ratio is 10:1. So you have to divide 110 by 10. That would be equivalent to 11 milligram of methadone. So if you start this patient on methadone, then tab morphine 5 milligram BD or syrup, tab methadone 5 milligram BD or syrup methadone 5 milligram BD would be enough. Are there any concerns for you with present medication? Amitriptyline has some interaction with methadone, but the dose of amitriptyline she is receiving is very low. So either you can stop it or you can continue, and you can plan to stop it once the patient gets good pain relief. So this is how you have to start methadone. Tab methadone 5 milligram BD, and morphine she was receiving 20 milligram. So 20 milligram Q for HSOS. Paracetamol, injection paracetamol is a very costly medication. Maybe 1 gram might cost between 300, 400 to 1000 rupees. So tab paracetamol 1 gram 6 hourly. The gabapentin can be continued, but with a note that we can actually stop it once the patient gets good pain relief with methadone. Amitriptyline and bisacodyl. And again, this patient was a nurse who was again confined to her room, and she had 2 kids, and she was very sad because she was unable to take care of them. She was unable to do anything except lying down in the bed. But after starting methadone, she was very active. She could do many things which she wanted to, including the first Holy Communion of her kids. So she was very happy till her end. So all these are real life stories. Now we are moving on to another patient, 40-year-old man with advanced malignancy of lung, and patient has pain metastasis due to T12 compression, for which he underwent radiotherapy to the spine 3 months back. Now he is complaining of burning pain on both lower limbs, continuous 9/10. He is on tab morphine, Q4H and SOS. This is just for calculation purpose only. So just calculate what is the dose of methadone this patient requires. Okay, I can see some answers again. Yeah, 12. Okay. So how do you calculate? She's taking 40 milligram of morphine 4 hourly. That means 40 into 6 to 40 milligram. So what would be the conversion ratio? she's taking more than 199 milligram of morphine. So the conversion ratio is 20:1. Okay, so 240 by 20, that would be 12 milligram of methadone. So maybe if you have only tab methadone 5 milligram BD or 5, 2.5 and 5 should also be okay. If you have syrup, then syrup methadone 4 milligram TID can be given with morphine on 40 milligram Q for exercise basis. And if you want to understand more about cytochrome P interactions, there is some web resources and you can visit this. And if you want to know more about methadone, there is a special supplement on Indian Journal of Palliative Care. So you can go through this. And this is the paper which I have mentioned for conversion of the present conversion method, safe and appropriate use of methadone in hospice and palliative care in Journal of Pain and Symptom Management. So what I want to tell you, even though I told you that I was afraid to start the patient on at first, and in 2018, from January onwards, we had methadone. But during that year, we started methadone only for 5 or 6 patients. But now I think at least 30 patients are on methadone. So once you have confidence in starting methadone, then there would be a subset of patients who would definitely be getting benefit with methadone. And you can, some of the important points about methadone are never increase the methadone before 5 to 7 days. And if you increase the dose of methadone, it is 5 milligram per week. So once you increase the dose of methadone 5 milligram, wait for another 1 week. So whenever you increase whatever be the dose of methadone, you have to wait for another 1 week in normal people. But in people who are elderly or people with liver failure, you have to wait for 10 to 14 days. And this is a safe medication in renal failure if the patient has pain. And if you use methadone in a lower dose, say maybe less than 50 milligram per day, then the problem of tau points and ventricular fibrillation, it is very unlikely. So, but you need to be careful about what are the medications the patient is taking. You have to review those medications and see whether any of these medication can interact with methadone and can lead to increased QT interval, or is it going to inhibit or induce the cytochrome P enzymes? So whenever you prescribe methadone, the prescription should be very simple. That's the basic thing. You should, we know that many of the patients, or I think almost all patients, would be on at least 15 medications. So there would be a chance of interaction. So you should be very careful when you prescribe methadone. Check the medication on what all medication are they getting, and then you can start the patient on methadone. So essentially, methadone would be very good for a subset of patients. So you have to select them. That's all. Thank you.
Excuse me, Dr. Sunil, someone has asked to share that conversion slide once again, please.
Yeah.
That one, yes. Thank you. And somebody has asked, can methadone be used in pregnant and lactating women?
So I have no experience, but opioids have been used in pregnancy and lactation. So as I am not an expert on that, I can refer and tell you, because we do not see patients with pregnancy.
Use in child.
Yeah. Child, it is very safe.
Okay, thank you, sir.
Thank you very, very much, Dr. Sunil, for taking them through in such a laboratory. So that's it. Generally, these drugs may be because of non-availability, or they've not seen, not known about it. It's better that you've made things crystal clear. As you mentioned, methadone might have been used as an alternative for psychological dependence type of issues. And this use, which is something, and mainly the cost queries also were there, which was answered. And somebody had a message in the chat about asking about tramadol cost, which I had replied that is tramadol costly, in that it is not costly. I had just posted the reply in the chat box.
So the order of or the price, my preference would be if the patient has moderate pain, especially if chronic non-cancer pain, tramadol would be started. But now even there is a thinking that do we need the WHO analgesic step ladder step two? Because instead of step two, some people considers low dose morphine can be used. So instead of tramadol, tapentadol, or codeine, use low dose morphine. Morphine is the cheapest, or sometime if the patient and methadone is almost comparable to morphine in terms of cost. Then comes tramadol. So I have shown you a slide in the last class. So 5 milligram of morphine, that is 30 milligram, which costs about 4 rupees. 4 rupees 50 paise. But to get the same pain relief, you have to use 300 milligram of tramadol, which may cost between 24 to 50 rupees. But whereas methadone might cost almost same 5 rupees. Tapentadol will almost be same as that of tramadol. Buprenorphine and fentanyl will be 100 times more costlier than morphine.
Anybody wants to ask anything? You can unmute and ask. If not, then I will hand it over to Sangeet. Thank you once again, Dr. Sunil.
Thank you, Dr. Sunil Kumar, for the wonderful and detailed presentation on management of pain. Thank you, Radha ma'am, for facilitating the sessions by answering all the queries and through the chat box as well. Thank you, everyone, for joining the sessions and making. Thank you, everyone. Let's see in the next section. Bye.
Thank you.